Now, my talk is on complications following hip arthroscopy. It's not the most glamorous talk of the day, but I feel that it's one of the most important ones. Now, complication rates following hip arthroscopy have been quoted to be between 0.5 and 5%. Namely, failed procedure, it can be, I can barely see from here, neurologic injury, it can be iatrogenic injury, and the rest as you can see. Now, the literature, when it comes down to discussing complications following hip arthroscopy, is still quite poor. There are a few papers out there that give us a journal outline. One of the first was by Professor Griffith and Richard Wheeler in 1999 that reviewed 640 patients and they quoted a complication rate of about 1.6%. Another paper later on was by Samsung that reported a complication rate of 0.5%, but mind you, he was discussing serious and permanent complications. Wheeler looked at the matter in more than 1,000 patients, and again, his complication rate was about 1.4%, a number that Illizatur in his paper a couple of years ago largely agreed. Now, all these papers, you realize they come from very experienced hip arthroscopies and very large volume arthroscopic centers. So I think it's quite wise when you're discussing with your patients to quote something that is a bit higher than that. And most of us do quote something between 3 and 5%. Now, let's do them one by one, the specific problems. First, it can be a failed procedure. Now, a failed procedure is defined when you're unable to enter either of the two compartments of the hip. And that can happen, and the patient should be aware of that. Now, patients that are high risk of that happening are patients that had multiple open operations around the hip in the past, obese patients, patients with heterotropic ossification or advanced OA or reduced range of motion. Another one is neurologic injury that is usually traction related. Now, usually, and fortunately for us, is only transient. It resolves a few hours, a few days post-op, and involves sciatic, femoral, pudendal, or lateral cutaneous nerves. Now, make sure, and you heard that before, and I'm going to insist on that, when you position the patient, is that the perineal post is large and it's well padded, the same with the foot plate, and do make sure that you monitor when you have the patient in traction for how long, and it certainly should be less than 2 hours. Scope trauma is another complication, or iatrogenic trauma, if you will. And it seems to be much more common than we realize, and actually might be one of the commonest complications and probably one of the most underreported ones. See, when you're doing the portals, when you're exchanging instrumentation, you can certainly damage the articular surface, especially the femoral head. And it is a complication that is seen in many of the revision cases, as one can imagine, it's a very difficult one to treat. The same with labor penetration. Now, these iatrogenic injuries have actually prompted some of the surgeons to start from the peripheral compartment first in order to minimize that risk, rather from the central compartment, and just to name a few, Thierry Boyer or Michael Dinst. What I tend to do in order to minimize that as a trick is when I apply the traction, initially I use a very fine thin needle, it's 18 Gs, not in the heat pack that you're used to. And what I do is it's very thin, it's not going to damage the articular cartilage or the labrum. Is as soon as you enter the hip joint, that is going to equalize the pressure within the hip, and the hip is going to open even further. And then you can distend the hip with further fluid, usually about 40 ml, and that also is going to give you the impression of an arthrogram. And do make sure when you're using the needles is that the sharp edge is facing away from the femorofemoral head, so you minimize the scuffing. And also you have the impression of the arthrogram because of the fluid that you already put into the joint. I was lucky enough to hear Dr. Bird a couple of years ago in the first ISA meeting. And at the time he said, and I think quite rightly so, that it's not an outstanding achievement with today's instrumentation to get into the hip joint, but certainly it is to not leaving any signs that you've been there. Now, FAI and residual FAI is another problem, and we know from literature that it's one of the main reasons to do revision surgery. So do make sure that preoperatively you plan and you make sure how much bone you're going to resect, and certainly make sure they have good imaging throughout the operation. Damaged instruments, you heard that before, they happen on a Friday. Guide wires can break, they can bend. Now, the comments are going to say that they're unbreakable, but believe you me, they can bend, they can twist, they can do all sorts of things if you're not careful. The same with the rest of the instrumentation. Anchors can also cause iatrogenic trouble with inadequate purchase. They can break, they can be malpositioned. HO, you heard from Richard Fields, is also a problem. It's not a very big one, but certainly I think it becomes routine now to suggest NSAIDs for 2 weeks following a hip arthroscopy. Pressure necrosis, it can happen the same with vaginal anal tears if you have overzealous traction. A fracture, I'm aware of only one report, and that's probably had to do with poor patient selection. AVN, you also heard about that. In reality, looking at the literature, there are only 2 cases in literature of AVN following hip arthroscopy. And saying that, in both cases, it was suggested that the blood supply was compromised beforehand rather than during the arthroscopy, because cadaveric studies has shown that if you use the proper portals, you don't really compromise the blood supply to the femoral head. Extravasation is another problem that we're becoming aware of. There has been a cardiac arrest report and abdominal compartment syndrome. You see, as our procedure becomes lengthier and lengthier, the same we have to be much more careful when it comes down to fluid management. Certainly, you have to be very careful when you're dealing with trauma cases with extravasation. We're discussing that a few months in Santander, and we have to give up at least about 6 weeks, the feeling was at the time, to allow for the capsule and everything else to heal. When you are dealing with trauma cases or very lengthy procedures, do make sure that you monitor the temperature of the patient, because if there's a temperature drop, it's the first sign that there might be large amounts of extravasation. A dislocation and subluxation has also been reported. There are a couple of case reports out there. So do make sure that when you're dealing with dysplastic hips, you're making sure you don't over-resect the rim of the acetabulum. Adhesions, they have been mentioned. Here are a couple of pictures that are provided to me by Richard Villar. Certainly what I do is I make sure I put them on a CPM immediately after the operation, use about like 30 to 70 degrees, and I make sure that they immobilize the same day. DVTs, there have been a few cases out there, I'm sure they have been discussed. I personally give DVD prophylaxis only high-risk patients, that is in their 40s, smokers, etc. Infection, very rare. I think it's been estimated that it's less than 1 per 10,000 cases. But nevertheless, I personally do give antibiotic prophylaxis on induction. Lastly, as we heard from Faris Haddad, the complication rates do become less and less as our experience grows. Certainly, though, when it comes down to concern and informing the patient, do make sure that they are aware of 2 things apart from the details. One is that the procedure might fail, it can happen, and 2, that can always make matters worse. Thank you very much.